Thanks for having me today. My name is Dr. Ted Schwartz. I'm a neurosurgeon. And I'd like to start today by bringing you into my operating room. So today we're operating on a 20-year-old girl with a tumor about the size of a chestnut in the center of her brain. She was diagnosed with it a couple weeks ago, came to see me in the office, and we've been in the OR now for a couple of hours. I made an incision in the back of her head. I removed a part of her skull. She's under general anesthesia. Opened up the covering of her brain called the dura. And for the last hour or so, I've been under a microscope dissecting my way between her cerebellum and her dura just to get to the tumor. So picture I'm in a chair that's motorized. My arms are supported by armrests to reduce my tremor. I'm working under a microscope because I'm working down a very, very deep, narrow corridor. And I'm moving bit by bit, making decision after decision. For example, I have to put a retractor on her cerebellum and gently push her cerebellum out of the way in order so I can see. And I have to figure out how much pressure to put on her cerebellum. If I put too much pressure, I could traumatize the brain and it'll swell up. And if it swells up, then I won't be able to see because it'll obstruct my view. And if I put too little pressure, I can't see anything. So I have a sense, based on the resistance that I'm getting when I retract on her brain, as to how much pressure I can put. And I keep making slow, steady progress. Up ahead of me, I see a vein, a blood vessel that's stretching in my way. And I realize that I'm not going to be able to get to the tumor with that vein in my way. So now I have to make another decision. What I really need to do is sacrifice the vein, which means cauterize it and cut it. But the risk is if that vein is critically important and I cauterize and cut it, then the brain could swell up. I could cause a stroke and leave this poor woman with irreversible brain damage. If I don't cut it, then I won't be able to do the operation, or it'll be incredibly hard to work around it. I probably won't be able to take the tumor out. So I look around, I see there's another vein nearby, and the hope is that that vein will take up the slack if I sacrifice this one. So I make the decision to take it, which means I cauterize it and I cut it and I wait. And I wait a few minutes and see what's going to happen, and everything seems to be fine. So I proceed dissecting deeper and deeper. Finally, I get to the tumor, and I look around, and the tumor looks similar to what I expected from the MRI scan, but a little bit different. I can see there's some blood vessels attached to it on different sides, and I have to figure out what's my best angle of approach. I thought I might go on the right side, but now I decide I'm going to go on the left. And then I start to feel the tumor and poke into it, and it turns out it's very soft and suckable, which is very, very advantageous for me because if it's soft, I can take it out more easily. So I core out the center of the tumor, and I'm left with a thick fibrous capsule. And I look around, and it turns out the capsule of the tumor is very stuck to a vein. And it's not just any vein, it's a big, thick vein called the basal vein of Rosenthal. And this is a vein that drains most of the blood from the center of the brain. So now I have another decision to make. There's a little bit of tumor left attached to the vein. I might be able to cut it off with a scissors. If I damage the vein and it bleeds and I have to cauterize the vein, then her thalamus will swell up to the size of a grapefruit. She'll probably never wake up again. If I leave the tumor behind, it may just grow back, and we may be back in this situation in another 5, 10, 15 years doing the surgery all over again. So I have to make this decision. At that moment, what runs through my mind is I think about this girl's two possible futures, right? In one possible future, I get the whole tumor out. She's perfect. She wakes up, she goes on with her life. She gets married, she has kids, she has a career. In the other possible future, I damage the vein. She maybe survives, spends a month in the ICU, a year in rehabilitation, and the rest of her life in a wheelchair, and all her dreams are shattered. And here I am having to make this decision. And I'm thinking, why do I have to make this decision? How can I possibly make it? How will I live with myself if I make the wrong decision? And this is the essence of what neurosurgery is. And it's a very difficult situation to be in. And I wish I could say it's an unusual situation, but it's one that I find myself in 2 or 3 times a week. It's very, very typical. And the point of this argument is that in this discussion is that we know that human beings are fallible. And at this moment in time, I'm thinking in myself, I know that I'm not perfect. I'm just a human being, and human beings make mistakes, and mistakes happen. And that's just the nature of neurosurgery. It's the nature of medicine that we're not perfect. And it reminds me of another story from when I was in my training. I was about 4 months into my internship. I had just started out. I barely knew my way around the hospital, let alone around a human body. And I was sitting at the nurse's station, and suddenly a code goes off, which is when a patient is deteriorating, and every available doctor runs to their bedside, just like on TV when you see it, to help this patient. So I run in there, and the more senior doctor runs the code. Luckily, my chief resident was there, so I was assisting her running the code, and she needed to give a medication, which means she needs to give it and then push it through the IV with saline or salt water. So she asked me to go run to the medicine cabinet and get her some saline. So I run to the medicine cabinet, and this is 30 years ago. So imagine I get into this room, and there are cardboard boxes filled with all different kinds of vials, and the boxes are wrapped in cellophane, which is torn, and the vials are lying all about. So I grab a vial and I run back and I draw it up into an IV and I hand it to her, and she pushes it into this woman's IV. And the woman, who's barely conscious at the time, kind of looks up and goes, "Oh my," and then her head collapses and she becomes immediately unconscious. And I look down at the vial in my hand, and it's not sodium chloride, it's potassium chloride. So potassium chloride, unlike sodium chloride, is potentially deadly. If you give a high enough dose, it causes cardiac arrest. It's one of the three medications that's given in the to patients, to convicts on death row. It's part of the lethal injection. And so I look down, and for a minute I'm thinking, oh my God, what do I do? What's my liability here? I've just killed this patient. And obviously that thought passes quickly through my head. And I tell the resident, chief resident, what I did. I confess. And she looks at the bottle and she turns around and saves that woman's life. So I'll never forget that moment. And luckily, now 30 years later, they no longer leave potassium chloride lying around the medicine cabinet in identical vials to sodium chloride. They have it locked away in a cabinet to prevent people like me, from early doctors, from making mistakes. But it raises the obvious question of um, why do we have to have humans in the mix here? And could a better outcome have happened because human beings are fallible, by bringing computers and robotics into this? And the real question is, could an AI do a better job? And can an AI replace a neurosurgeon? Can an AI and a robot do a better job? So we know that AIs have infiltrated into medicine already and are doing incredible things. They can read scans and pathology slides better than human beings. You feed in a million slides or imaging studies, and they'll tell you and they'll learn what's normal and what's abnormal. As long as you tell them, give them an outcome, they'll be able to do it better than a human being. And so it's not a crazy question to think an AI could do neurosurgery better than I could. And if you think about the history of neurosurgery, it's really been marked by incredible technological progress. So, for example, Harvey Cushing, who's the founding father of neurosurgery, in 1905, when he started practicing, the mortality rate of neurosurgery was 50%. So think about it, half the patients he would operate on would literally die either on the operating room table or soon after because of blood loss or infection. And when he was done with his career in 1935, that came down to 8%. So it's been remarkable. I can tell you from my own surgical practice that as a tumor surgeon, I was trained to take out tumors in the center of the brain by making a giant skin incision, flapping the skin down, taking down the muscle for chewing, removing a giant piece of the skull, and then working around the brain or even through the brain to get to the tumor. And now I can take out that same tumor just going up through the nose with no incisions using an endoscope, which is like a long, thin telescope and very specialized instruments to go up through the nose. Same is true in epilepsy surgery, another specialty of mine. We used to put electrodes in the brain by opening up, again, a big incision, remove massive part of the skull, put these big grids of electrodes on the surface of the brain to record where seizures are coming from, and then remove chunks of brain. Now we can do that same operation by making little teeny slit incisions and having a robotic arm that tells us where to put the electrodes through a tiny little hole and a spaghetti thin electrode that goes into the skull. And then we can remove those epileptic foci basically by slipping a little laser probe into the brain and burning it from the inside out. So it's not crazy to think, given that progress, that maybe where we're going is robotic neurosurgery. Uh, and we even have a GPT called Atlas GPT in neurosurgery, where you give it a neurosurgical problem, and it'll tell you this is the operation you should do, and it'll give you every single step that you need to follow to do that operation, like a cookbook or a checklist, almost like assembling an IKEA dresser. So the question is neurosurgery just like building furniture or landing a plane? Is the same thing? And the answer is going to be no, but let me explain why. So let's go back into the operating room. So there I am poised over this tumor. I've got a micro scissors in my hand. I've got to make this incredibly important decision. So the other thought that comes to my mind is I think back to my first office visit with that patient and her father, meeting her in the office. And I'm sitting there telling them what I'm going to do, and I'm answering all their questions. And her father pulls me aside at the end of the visit and he says, I want you to make me a promise. And I'm like, sure. He goes, look, I know you're supposed to be one of the best surgeons, but I want you to promise me that you're not going to hurt my little girl. And I got it when he said that. I have children of my own. I knew exactly what he was talking about. And neurosurgery and medicine is a deeply human uh, connection between human beings. Um, I remember when I decided to go into neurosurgery, my mother was very disappointed. And I was like, why are you disappointed? She goes, well, neurosurgeons, they're like cold, calculating technicians. I thought you were going to be a pediatrician. You're this warm, sensitive person. And that's definitely the reputation of a neurosurgeon. But it's really not accurate. Neurosurgery is very human. In fact, there's another operation that we do that I love doing, which is awake surgery. And I'm sure you've read about this kind of stuff where we have a patient who's on the table and they're awake during brain surgery. Basically, the pain fibers that you have are in the skin or in the covering of the brain called the dura, but the brain itself has no pain fibers. It does not know if you're touching it. It does not know if you cut into it. So it's possible to have a patient anesthetized on a table with their skin anesthetized and them fully awake and talking and interacting with you. And the question is, well, why would we do surgery like this? It turns out that there are parts of the brain that are important for moving the arm and parts of the brain important for speech and language. And the brain has no labels on it. So you don't actually know where those areas are until you're in there operating and looking at it. And the way we figure it out is we stimulate the brain. And if someone's speaking, they'll have trouble speaking when you stimulate the part of the brain that's important for speech. And so we'll do surgeries with patients fully wide awake. And we'll have to carry on a conversation during the surgery. So I'll be asking them about their kids. I'll be asking them about their favorite movies, about their favorite books. I'll be talking about myself, anything to keep them engaged, to keep them comfortable so they don't panic, they don't become anxious. And we have to create that human connection in order for the surgery to be successful. So it's not dangerous for them. And so we can accomplish what we need to do. So that human connection and humanity is very important for this type of surgery as well. But you could then ask yourself, all right, so you could have a human being in the operating room helping you, talking to the patient, but like you still have to make these technical physical decisions. Like, wouldn't a robot be better at doing that? A robot doesn't have to sit on a motorized chair to reduce tremor and brace their hands. They don't have to hold their breath. They don't have a tremor. So why not have a robot do the surgery? And the answer is that neurosurgery is very different than furniture building. There's a famous saying by Mike Tyson, everyone has a plan until you get punched in the face. And neurosurgery is very much like that. And you can think about the difference between um, neurosurgery and other types of calculating puzzles, like the difference between chess and Jenga. When I'm in the operating room, I'm making a million decisions, and those decisions are not always mental calculations like calculus, but they're physical decisions. I'm having to solve a physical problem. If you think about chess, chess is played on a rigid board. It's the same size every time. The pieces start out in exactly the same location, and the pieces have defined rules. They can only move in certain ways, and there's a defined objective. The board is not going to suddenly in the middle change from a rectangle to a trapezoid. And, the rook is not going to suddenly go rogue and start jumping over pieces, to attack the queen. Um, computers are very good at chess because they're defined rules. And AlphaZero, which was an AI program, taught itself how to play chess in about 4 hours and became the greatest chess player in the world. But neurosurgery is a little more like Jenga. In fact, it's like on Jenga on steroids. Jenga, there's a lot of physical problems that you have to solve when you pull out those bricks. And it's a four-dimensional time space kind of interaction. And robots can play Jenga, guided by an AI. That's been done. But if you make the pieces slightly different sizes and you make the consistency, some are more rough and some are more smooth, the robots fail horribly at that. They're really not good at it. And that's really what neurosurgery is like. It's almost like Jenga on steroids, where we have to make 1,000 decisions. I like to say it's like playing a soccer game on a field the size of a postage stamp, where like every minute you're making another physical decision. And if you think about it, um, that's exactly what human beings were designed to do. We were designed to solve physical problems. We evolved on a planet that was inhospitable, trying to kill us, where we had to find food and find shelter and evade predators. And that's a lot of physical problems that we had to solve with our bodies. We had to find a mate and learn how to reproduce. We had to build societies, and computers just don't have to do that. Computers still live in the Garden of Eden. They live in a box on their designers' desks. They don't have to search for food. They're plugged into an outlet to get power. They don't have to learn how to adapt to survive. So computers are very good at solving complex problems with lots of variables that humans can't grasp, but they're really bad at solving physical problems. They lack what I call physical intuition. Human beings have physical intuition. So if you're playing a game of chess, by all means, you should use a computer. But if you're in the operating room and you're making a decision, a physical decision, you're better off having a human brain on your side. So if we go back into that operating room one more time, where I'm sitting in there with my micro scissors having to make a decision, I then ask myself a question that I don't think an AI can ever answer. And it's the most important question that a surgeon can ask themselves at that moment in time. If it were me lying on the table or my child, what would I want the surgeon to do? Uh, and a computer has never loved. It's never felt pity. It's never felt grief. It's never been to a wedding or a funeral. It's never attended a graduation ceremony. It doesn't have that wealth of human experience that goes into making these kinds of decisions. So at that moment when I have to make that decision for myself, I think about my daughter lying on that table. I think, what would I want done if my daughter were there? I think about her dreams and her aspirations, and what would I want the surgeon to do? The tumor is benign, and sure, if I leave a little bit behind, it might grow back, but it might take 20 years to grow back. And that this girl has a lot of living to do in the next 20 years. So at that moment, I stop. I tell the nurses we're closing, the operation is finished, because I made a promise to another father to keep his little girl safe, and that's exactly what I intend to do. Thank you very much.